Congenital, hypertrophic, pyloric stenosis, understanding pathology and clinical presentation. Congenital pyloric stenosis, also known as hypertrophic pyloric stenosis, HPS, is a condition that primarily affects infants, leading to the obstruction of the gastric outlet. This video aims to explore the pathology of congenital pyloric stenosis and its associated clinical presentation. Pathology of congenital pyloric stenosis. Anatomical considerations. Congenital pyloric stenosis involves hypertrophy and hyperplasia of the circular muscle layer of the pylorus, the muscular valve between the stomach and the duodenum. This hypertrophy results in the thickening and elongation of the pyloric muscle, leading to the narrowing of the pyloric channel. Etiology and genetic factors. While the exact cause of congenital pyloric stenosis is not fully understood, genetic factors play a significant role. It is more commonly observed in firstborn males and has been associated with a positive family history of the condition. Some studies have identified a possible genetic link with certain genes implicated in the development of hypertrophic pyloric stenosis. Pathophysiology. The hypertrophied pyloric muscle causes functional obstruction of the gastric outlet, leading to difficulties in the passage of food from the stomach to the duodenum. This results in vomiting, which initially may be non-bilious and projectile. Persistent vomiting contributes to dehydration, electrolyte imbalances, and failure to thrive. Clinical presentation of congenital pyloric stenosis. Age of onset. Congenital pyloric stenosis typically manifests between the 2nd and 8th weeks of life. Infants are born asymptomatic but gradually develop symptoms over this period. Vomiting. The hallmark clinical feature is forceful, projectile vomiting, often occurring after feeds. Vomiting tends to be more pronounced after the first few weeks of life, becoming progressively forceful as the condition advances. Palpable olive-shaped mass. On physical examination, a skilled clinician may detect an olive-shaped mass in the upper abdomen. This mass represents the hypertrophied pyloric muscle and is most palpable after vomiting episodes when the stomach is empty. Dehydration and weight loss. Frequent vomiting leads to dehydration, electrolyte disturbances, and weight loss. Infants may exhibit signs of lethargy, decreased urine output, and a sunken fontanelle due to fluid loss. Diagnostic evaluation. 1. Ultrasound. This imaging modality is the primary diagnostic tool, revealing the thickened pyloric muscle and characteristic target sign or donut sign. 2. Laboratory tests. Blood tests may show evidence of electrolyte imbalances and metabolic alkalosis due to persistent vomiting. Management and treatment. Surgical intervention. The definitive treatment for congenital pyloric stenosis is surgical pyloromyotomy. This procedure involves making an incision through the hypertrophied muscle, relieving the obstruction and restoring normal gastric emptying. Preoperative stabilization. Prior to surgery, infants may require correction of fluid and electrolyte imbalances through intravenous hydration. Prognosis. With timely surgical intervention, the prognosis for infants with congenital pyloric stenosis is excellent. Surgical pyloromyotomy effectively resolves the obstruction, allowing for normal feeding and growth. In conclusion, congenital pyloric stenosis is a condition characterized by hypertrophy and hyperplasia of the pyloric muscle, leading to functional gastric outlet obstruction. Early recognition of the clinical presentation, including forceful vomiting, palpable abdominal mass, and signs of dehydration, is crucial for prompt diagnosis and intervention. Surgical pyloromyotomy remains the gold standard for treatment, ensuring a favorable prognosis for affected infants.